in context of CAR T therapy with certain constructs. The incidence of a patient experiencing cytokine release syndrome is higher than 90%.
I think with all of the new immunotherapies coming out, this is definitely something that new nurses and nurses that maybe have been in the oncology field for a while just haven't seen as frequently, and it's important for them to know.
Absolutely. I think oncology nurses in general are amazing at managing and recognizing and treating cytokine release syndrome because it does mirror sepsis so much.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Theresa Latchford, Clinical Nurse Specialist at Stanford Health Care in Palo Alto, California, and member of the Silicon Valley ONS Chapter, to discuss cytokine release syndrome, which we'll abbreviate to CRS from now on, and its associated immunotherapies. This episode is part of a new series about oncologic emergencies. We'll add a link to future episodes in the show notes when we share a second episode next month. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Theresa.
Thank you for inviting me, Stephanie.
Great. So to start us off, can you give us some background on CRS? How does it present?
There are 3 manifestations of cytokine release syndrome that the nurse really needs to look out for. And the first and the most common is fever. And then the other 2 changes is blood pressure, hypotension, and or any respiratory changes.
Okay. So now that we kind of know what those things are that we're going to be looking for, what immunotherapies are most often associated with CRS?
CRS in the nursing literature was actually, CJON has a great article from Sheila Breslin back in the early 2000s. So this is something that's been around for many years, cytokine release syndrome or cytokine storm. And it was first documented in use with immunotherapy and including the monoclonal antibodies. And that first article spoke of cytokine release syndrome in context with Rituxan, as that was approved for nursing on how best to manage it. So other immunotherapies such as monoclonal antibodies, you will see cytokine release syndrome. Certainly now, if you work with hematology patients with Blincyto or the bispecific, the BiTEs, you can see it, or with immunotherapy such as ATG or Campath, you can also see cytokine release syndrome. But I think more commonly, oncology nursing is seeing it now in context of CAR T therapy, chimeric antigen receptor therapy, where the incidence is much higher with certain constructs. The incidence of a patient experiencing cytokine release syndrome is higher than 90%. So it's not really an issue of if the patient is going to experience cytokine release syndrome. It's more of an issue of when they will experience it. And so that's important, I think, for the nurses to know that it is very common when dealing with chimeric antigen receptor patients, more common than with other types of immunotherapy.
Okay. You mentioned if you work with in the hematology kind of area. And I can definitely remember, working with bone marrow transplant patients and things like that, that we definitely saw that. But would you say that it's something that is seen now kind of across the board, whether that's in solid tumor or heme malignancies?
I definitely think cytokine release syndrome is a term that is being used more frequently and is more across the board, definitely with solid tumors and certain treatment options, as well as in blood and marrow transplant and maybe a flare-up of graft versus host disease, as well as CAR T therapy.
Okay. I just wanted to clarify that. We have a lot of listeners that are new nurses to oncology who definitely work across, the different diagnosis areas. So I wanted to just clarify. And so as they're listening, it's not something that someone's thinking, oh, well, I don't work in hematology, so I'm not ever going to see that. But I think with all of the new immunotherapies coming out, this is definitely something that new nurses and nurses that maybe have been in the oncology field for a while just haven't seen as frequently. And it's important for them to know.
Absolutely.
So, Theresa, can you tell us, is CRS preventable?
I don't think it's necessarily preventable, but there are things that we do to kind of mitigate or to kind of lessen the incidence. So, for example, in CAR T therapy, we may choose to give chemotherapy to try to lower a disease burden before they come in for treatment. So we know that with CAR T therapy, the activation and the engagement, and as the CAR expands, patients are more at risk for cytokine release syndrome. So with CAR T therapy, you have a target, and the commercially approved targets for lymphoma are CD19 and for multiple myeloma is BCMA. And as that CAR attaches to the target and kills it, they are at risk for cytokine release syndrome. So if we see a patient prior in clinic and they have a really high disease burden, before they come into us, the physician may try to bridge them with some more chemotherapy to try to lower that disease burden. So they'll still be at risk for cytokine release syndrome, but if their disease burden is kind of taken down a notch, it might not be quite as bad. Other things that we do to kind of lessen, and again, not necessarily prevent, is that the physician may choose different constructs or different types of CAR T therapy. There's different manufacturer FDA approvals, and they behave differently. So one may have a lower incidence of CRS because it doesn't expand exponentially as quickly as another one. And so the physician may decide to give that type of therapy to a patient. So again, it's not necessarily preventable, but there are things that may lessen the incidence to it for CAR T therapy.
Okay, that's really good to know. I think that's something that's really important because, with oncologic emergencies in general, those things tend to come up very quickly. So if there are things that we can prepare for that we know that might help, lessen the possibility, that just, I'm sure, kind of relieves some of the concern or anxiousness that both nurses and patients would have, when they're being given a treatment that this might be a potential side effect for.
Absolutely. I think if a nurse comes in the morning and has her patient assignment and the patient is being infused CAR T cells and they have a good understanding of the type of CAR that they're receiving, as well as the patient's disease burden, which would be their high risk. Those are their two high risk factors at that point for cytokine release syndrome, can really help them with their assessment in the next few days for managing the patient and being proactive in dealing with cytokine release syndrome.
Yeah, that's really true. And that's another reason why it's so important for nurses to, be aware and understand these treatments. And as they're coming out, especially, as quickly as things are coming out, what the potentials are with these treatments. So let's talk about the patients that are most at risk for developing CRS. Who might that be?
So I think, as I mentioned before, is anyone with a higher disease burden. If it is a lymphoma patient, it would be found on PET scan. If it is a B cell ALL leukemic patient, they may have a very high blast count. So those are things that a nurse can determine that would put them at higher risk for developing cytokine release syndrome, as well as I mentioned, the type of construct or CAR T therapy that the patient is receiving. There are different co-stimulatory domains that activate and engage the CAR T. And certainly the domain with CD28 is known to expand quicker and sooner than the domain with a 4-1BB construct.
Good to know. So now let's talk a little bit about, what the nurses need to know. What are some of the most common nursing considerations for CRS?
So cytokine release syndrome manifests itself in the three main symptoms that the nurse needs to look for is fever, hypotension, and respiratory changes. So I think the main nursing considerations revolve around that. When you're dealing with any oncology patient, and you say fever and low blood pressure to a nurse, the first differential that they're thinking about is sepsis. So I think, it's important for the nurse to consider the differential between sepsis and cytokine release syndrome. And regardless, the nursing actions are going to be geared toward both. So really, the infectious disease workup needs to be completed. And the nurse in their assessment, is there anything abnormal that would think they would have an infection, their lung sounds or their urine, or maybe if the patient had disease in their bowels, are they having any bowel issues along with the fever and or the low blood pressure? And then as far as the differentiation between cytokine release syndrome, the nurse is still, managing the fever and the low blood pressure, but also kind of taking into consideration what's going on with the immune system. And so it's important for them to follow the C-reactive protein, which is one of the kind of common nursing workflow. Each day you kind of want to follow that because you can see it's kind of a global lab indicator of inflammation. And so oftentimes you can trend that in the early days as it's rising in context to what's going on with the patient, if they're having fevers and or low blood pressures or respiratory changes.
Those are some really important things. And like you said, with the fever and the blood pressure, and what our, thoughts immediately go to is sepsis. And, again, how important it is to be able to kind of think through and differentiate between, okay, is that the direction that they're going, or what was the most recent treatment that they had? And could this be a CRS and not going in that, in the sepsis thought process right away?
Another consideration, I think, for the nurses as well is CRS is graded on a scale of 1 to 4, whereas 1 and 2 is most common, and that's kind of a little mild and bothersome to the patient, whereas the grade 3 and 4 is life-threatening, and meaning that it's potentially an ICU stay for many patients. And so for the nursing staff, if a patient presents with maybe fever, low blood pressure, they've given them a little fluids, but really doing that post-assessment Has the patient stabilized? Did their temperature come down with, the antibiotics, the Tylenol? Did their blood pressure resolve with the fluids? Are they still oxygenating okay? So really kind of that reassessment throughout their shift is very important with cytokine release syndrome, because it can certainly progress to potentially life-threatening very quickly. And so with that grade 3 or 4, then you're really talking about with cytokine release syndrome that you're also adding into more medical management and pharmaceutical medication treatments.
Yeah, some really good points there. Thank you. So are there treatments to manage CRS? And, if there are, what would the nursing considerations be for their administration?
So for grade 1 cytokine release syndrome with CAR T therapy is generally it's supportive. So you may give Tylenol, ice packs, maybe if their platelets are above 50, an NSAID if the physician thinks that's warranted to help bring their fevers down and the patient's more comfortable. If it's a grade 2 and their blood pressure is low, interventions really include fluid boluses, as well as, trying to keep that temperature down and the patient maintained. But really, at this point between grade 2 and grade 3, the mainstay of treatment for cytokine release syndrome with CAR T therapy is tocilizumab. And tocilizumab, it blocks the receptor for IL-6. And IL-6 is one of the proteins or the cytokines that is most studied with CAR T therapy. So patients will get a dose of tocilizumab, and in general, they respond very quickly to it. So for me, when I teach nurses, I just say, when you do that intervention of tocilizumab, when you're following the patient for the next 2 to 4 hours, they should resolve their temperature and or their blood pressure. And if you're getting toward the end of your shift and it's about 6 to 8 hours and the patients are still in that same grade of cytokine release syndrome, then chances are they may need another dose of tocilizumab or a little bit stronger interventions such as vasopressors for blood pressure support or higher oxygenation. So tocilizumab is the mainstay of treatment, and it blocks the IL-6 receptor, one of the cytokines. But also, if it is more severe and life-threatening and they're needing ICU support and vasopressors, then usually we add steroids onto that, and that helps dampen that immune system response or puts the brakes on the cars a little bit so that the patient, it brings them back down into kind of a grade 1 or a grade 2. We don't want patients to have a life-threatening grading of cytokine release syndrome. We want to try to avoid that.
Well, that's definitely good news that there is something that can be administered, and just the importance of knowing about that. And again, just that whole assessment piece of how important it is to know when, a patient might need to go in that direction. So I want to ask about a different patient group, and that would be our gero-oncology patients. With CRS, is there anything special or different about that patient population that needs to be considered?
So I think in context of CAR T therapy, when you're dealing with B-cell ALL, we don't see a lot of the gero-oncology patient population. Usually they're a little bit younger, in their 20s to 40s for us on the adult unit. But for lymphoma, certainly it's not uncommon that disease is diagnosed in the 6th, 7th, even 8th decade. So if a patient is in their 70s and they have cytokine release syndrome and they're fevering for many, many days, then it can really take a little bit of a harder hit on their body. And so I think what I've seen in not all, but some of our older patients is that their nutrition, their mobility, their recovery time they can get just hit a little bit harder than someone in their fourth decade. So, nursing may, for that group, just really staying on top of their nutritional intake and or an early PT consult or an early PT assessment on how best to help these patients recover. And so the longer, if they have fevers for 3 days, it may not affect them so much. But if they have fevers for 5 to 7 days, they can just be hit a little bit harder. So that might be that patient group that if Tylenol's not bringing down, if PO Tylenol is not bringing down their temperature, maybe the nurse tries IV Tylenol, or maybe they add in an NSAID if their platelets are above 50 or something like that, so that they're just not quite as wiped out when they do recover from the treatment plan.
Yeah, that's really good information and something that is good to think about, because we do have, those patients that, might be in that population, as well as, just making sure that, anybody that might have some additional comorbidities that we have to take into consideration when administering these treatments. So how can oncology nurses educate patients on CRS before and during their immunotherapy treatment?
Because CRS is so common with CAR T therapy, hopefully many centers have cytokine release syndrome built into their patient education. If they get a patient education treatment book, many of the manufacturers of the specific constructs have pretty good patient education. But for CAR T therapy, all patients receive what's called a wallet card. And when the FDA approved the CAR T therapy, they approved it under the REMS program, and REMS stands for Risk Evaluation Mitigation Strategy. And that just said, because cytokine release syndrome as well as neurotoxicity is potentially life-threatening in CAR T therapy, that patients need to be educated about it. And so they're provided this wallet card either before or on the cell infusion day. And the wallet card kind of summarizes the fever, low blood pressure, respiratory changes, as well as some of the neuro changes. And so patients do need to stay locally for 30 days at the treatment centers, as well as if for some reason they needed to go to the emergency room, they need to show this wallet card. So I think using the wallet card as a method of education for nurses to have those conversations with the patients, but also utilizing whatever the institution-specific education materials have can be quite helpful.
It's really good that there are those resources available. I think it's so important for our patients to know and understand. It gives them some control over, or, just that understanding of what kinds of things to look for, and that they, hopefully don't feel completely in the dark, as overwhelming as all of this can be.
Well, the education is extremely important because it's hard for patients to be knowledgeable on all the side effects that can happen. But because cytokine release syndrome and neurotoxicity, the incidence is so high, by, reviewing the wallet card, before the infusion, and then as they experience it during, or if they are outpatients, it just helps reinforce that they need to call and notify someone if they have a temperature, instead of thinking this is a normal side effect, I'm not going to call anybody. So it just kind of drives home the importance of the side effects for both, I think, the nursing staff, the physician team, as well as the patients, by providing the wallet card and kind of using that as a method of teaching.
So Researchers say some patients who develop another major toxicity from CAR T cell therapy, which we've been talking a lot about, with clinical features of immune effector cell associated neurotoxicity syndrome. We can call that ICANS. Will have preceding CRS. In this instance, CRS can be considered an initiating event or, kind of like a cofactor for ICANS. How do the two neurotoxicities differ in how they present?
Essentially, ICANS can occur independently of CRS, which is not as common. More commonly, ICANS occurs concurrently with CRS, or it can occur without any CRS. So I think for a nurse caring for a CAR T patient, when a patient experiences cytokine release syndrome, that they would then anticipate the neurotox to then develop. And again, it's important for the nurse to know what construct or what type of CAR that the patient received and what is their tumor burden, because that can give clues to the nurses on how quickly when the ICANS occurs, what day post infusion, as well as the incidence, if it's a 5% incidence of a very serious ICANS or a 31% incidence of severe ICANS occurring.
Thank you. That's really good information and so important. So do oncology nurses need to adjust their management and treatment approaches because of this?
So the treatment approaches for ICANS is different than cytokine release syndrome. So, however, having said that, if a patient experiences a neurotoxicity while they're having concurrent CRS, so they are starting to have mild confusion or word finding issues, and they're having a fever along with it, then the treatment management consists still of the tocilizumab, the IL-6 receptor blocker that we talked about previously. But the mainstay really of management with neurotox would be steroids.
Well, the next question I'm going to ask you is, how can the cancer care team take steps to prevent ICANS in a patient that's diagnosed with CRS?
I wish we had a method to totally prevent it, because it's definitely one of the harder things that patients experience with CAR T therapy. But I think a role that's pivotal for nursing is early detection, which means more frequent neuro assessments and really knowing your patient. So this is, I feel like, catching early neurotox is an opportunity for growth within nursing and our medical teams. That we're great oncology care practitioners, but now we're adding into this whole field of neuro changes that is a little bit different for our oncology practitioners. So really, for me, when we move a patient into the window that they may experience neurotox, really having the nurse who knows the patient, who has gotten a rapport with the patient, can be very helpful to find those subtle changes early on that the patient's having. Also, the nurse may have to utilize the family to say, is this type of response or behavior with the patient, is that normal? So sometimes I'll ask, if we have a new nurse caring for a patient who hasn't had them before, sometimes it's helpful if somebody else on the unit who knows the patient or has cared for him in the past, if they can pop in the room, because there's really a lot of subtle signs and symptoms that can occur early, that if the nurse is on their game with their assessment, that you can pick up on, your grade 1 neuro changes a little bit earlier. So, for example, a patient might just repeat maybe 3 times, what was my blood pressure? They may not remember, or they may start to repeat that to a nurse. And that may not seem totally abnormal out of context, but it could be an early indicator. As well as oftentimes patients may have some incontinence, and they may come up with a whole reason for why they couldn't get to the urinal on time or something. And it may make sense when the patient explains it to the physician team. But when you put a lot of these little subtle changes together, it really ends up that it could be the beginning of mild confusion, and this ICANS is starting.
I saw somewhere, Theresa, where they recommend using with patients that either you're concerned might have an ICANS response or have already started kind of showing some of those beginning signs, by having them write their name, or just even asking them to draw, let's say, a square. And then you have one piece of paper where you keep asking them when you go in and do your assessment, okay, can you just draw a square for me, and see how that changes and how much of a predictor that is even on how quickly things are changing, or quickly, for the worst or getting better. And I thought that was a really neat approach also in using that as an assessment tool.
Absolutely. The handwriting analysis is part of the 10-question ICE, the immune effector cell associated screening tool. That you have your orientation questions, you have 2 simple commands, you have write a simple sentence is what we say to patients, as well as we ask them to count backwards from 100 by 10. And that monitors their attention. So oftentimes you can see some of the first changes is they can have a change in their handwriting. They can do an upward slope. Oftentimes, as a nurse watches a patient do the handwriting analysis, you can see that maybe a patient's having difficulty with word finding, that maybe they want to put like, I miss my cat, but they were struggling to kind of come up with the word cat. So it's important for nurses not only just to hand the paper to the patient, but also to kind of watch them form, and how easy is it for them to write that sentence and kind of come up with the sentence. In counting backwards, oftentimes patients will make it to about 60, and then they kind of forget their attention, what they were doing. Some of them can restart at 60 and count down the rest of the way and finish it. Others may make it to 30 and then have to restart. So those are all the very subtle signs that something's starting to happen. And again, I think it's the early assessment and the early detection, and then knowing that then if it's starting to happen, you need to do more frequent assessments on the patient to make sure it doesn't progress to serious and life-threatening, because ICANS can progress to grade 3 and 4 very quickly within hours and can be very challenging to manage.
Well, Theresa, this has been extremely informative, and I think that our listeners are really going to appreciate the information that you have shared with us today. And I appreciate you being on here and taking the time. To finish up today, I have some quickfire questions that I like to finish each of our podcasts with that I'd like to ask you before we sign off. So the first one is, what are some common misconceptions about CRS?
There are some common misconceptions that people and even I've had patients that have been scared for us to treat cytokine release syndrome with tocilizumab, and if they need some steroids with it, that they think it's going to remove the efficacy of the treatment. So that the medical management, the tocilizumab and or the steroids, dampens the immune effect. It puts the brakes on the car, but we know from studies that a little bit we need that to prevent them from progressing to a life-threatening grade of cytokine release syndrome or neurotox. And so I think, one of the misconceptions with patients is that oftentimes we do have to use those tools in our toolbox. And, we know that by putting the brakes on a little bit, it won't hurt the efficacy of the CAR or the whole goal of the treatment of the CAR, which is our intent to hopefully cure the patients.
Next, what is something about CRS that's not often discussed, but you wish people knew more about?
We know a lot about IL-6, but I can't really say something that I just wish in general we knew more about even all the other cytokines. And I look forward, we're still young in our profession with CAR T therapy and cellular therapy, that I look forward to learning more about the different cytokines and perhaps other management for patients other than just with IL-6.
What additional training or education do oncology nurses need to manage and treat CRS?
I think oncology nurses in general are amazing at managing and recognizing and treating cytokine release syndrome because it does mirror sepsis so much. But I think in general, if they need to learn more, the Oncology Nursing Society has amazing videos and handouts on cytokine release syndrome. There are apps as well that are available that staff can kind of put in the symptoms that the patient's experiencing, and then they can click on a management strategies, and then out pops some management strategies. And I think that can be helpful, especially if you're on night shift and you may not have all your team there to support you. That can often give the nurse different ideas to advocate for the patients if they have an on-call or a hospitalist who might not be as familiar with managing these patients. So I think those are tools that often I recommend to staff who want to learn a little bit more and feel a little bit more comfortable when they're caring for patients who have cytokine release syndrome.
Okay. And are there additional resources for patients then who want to learn more about CRS?
The BMT InfoNet has patient information, as well as the Leukemia, Lymphoma, and Myeloma Society has patient education that they can also learn about CAR T therapy and cytokine release syndrome.
Well, again, Theresa, thank you so much for joining us today. And before we end, do you have any final comments?
Nothing. I really appreciate you taking the time to talk to me about cytokine release syndrome. And I just really look forward to the future as nurses better learn to manage and care for the patients who have both cytokine release syndrome and ICANS. So thank you for taking the time to talk.
Well, thank you for joining us today.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.